Hello and welcome to Early Hearing Detection and Intervention for EHDI Hospital Contacts, Part 2. If you are watching this presentation, I sincerely hope you've already watched our EHDI overview for Hospital Contacts Part 1, and if not, I would suggest that you find the link for that presentation and start with that. My name is Kathy Avini, and I work with the New Jersey Department of Health and Senior Services with the Early Hearing Detection and Intervention, also known as EHDI program. The target audience for this presentation is hospital staff that have administrative oversight of newborn hearing screening in New Jersey hospitals. So it's not targeted at individual screeners. As I mentioned in Part 1, we recommend a national training curriculum video for that training. This is more about hospital obligations and regulatory obligations. This presentation will focus on the hospital's regulatory requirements for newborn hearing screening, picking up where we left off last time. And the remainder of the regulations that we didn't cover in the prior presentation focus mostly on communicating results to parents and taking steps to increase the likelihood that babies that do not pass our inpatient screening will receive necessary follow-up testing. As you watch this presentation, please feel free, and I encourage you to jot down any questions you have that are not answered in this program and send them to the Department of Health staff. I'll give you contact information at the end of the presentation. And we'll respond to your question. I also intend to create and maintain and post a frequently asked questions document to accompany this presentation. You'll notice that the subheading of today's presentation is hospital responsibility for ensuring outpatient audiologic follow-up. You may be asking, why do hospitals have any responsibility for ensuring outpatient follow-up for newborn hearing screening? You may think, well, the state does follow-up on abnormal blood spot screening results, why not hearing? One thing that's important to keep in mind is that with blood spot testing, the results are obtained in the Department of Health labs and are available to Department of Health staff as soon as the positive screen is identified. In comparison, a hearing screening test is done at the baby's bedside in the hospital. So it's your hospital staff that are immediately aware of the results to be able to provide appropriate next steps. Pulse oximetry screening similarly relies on hospitals to take appropriate follow-up action and next steps. For hearing, even under ideal conditions, it may be a week or so before the refer result is entered into the birth certificate system, then submitted to vital statistics, and then passed on to the Department of Health EHDI program. So in some cases, reporting of a refer result may be even longer, and maybe when a baby is considerably older. Also, there's a fee that is paid to the state for each blood spot test result that supports the staff positions required for doing the testing and follow-up. The Department of Health Hearing Screening Program has no such dedicated funding source. Our staff is currently funded off of several federal grant sources with uncertain futures. So one of our goals is to support hospitals in creating a hearing screening program at their facility that can be both effective and potentially self-sustaining. So picking up where we left off last time, we are at Section 1.8 in our administrative code, which starts talking about high-risk indicators. The rules refer to the current JCIH, that's Joint Committee on Infant Hearing, position statement to identify what risk indicators we identify as children that need additional follow-up. At 1.8a, our regs specifically state that it's the physician that's responsible, a child's primary care physician that's responsible for referring children who have a high-risk indicator for additional follow-up. However, the hospitals do have some obligations as well, and at 1.8b, we say that hospitals must follow ototoxic medication policies for admissions on children aged 0 to 3 that are given ototoxic meds. Now, as I mentioned in part 1 of this series, I'm focusing mostly on things that are required by regulation, and those items that have been preceded with relevant citation to the rules, as you see here with the A, B, and C, are requirements. As we do continue, I will be pointing out some things that are suggestions about things we feel are best practices that we have identified from other facilities, and we would encourage you to use those suggestions, but we don't require it. And I'll try and be clear during this presentation to differentiate between your requirements and our recommendations. So everything here is a requirement. For item B, I also mentioned during part 1 that one requirement of your hospital's newborn hearing screening policy was to include an ototoxic medication policy. That policy needs to cover not just infants that are born at your facility, but should also cover hearing screening guidelines for any children that are birth to age 3 that are admitted to your hospital and at some point after the birth admission receive ototoxic medications. Now, the Joint Committee on Infant Hearing position statement does not spell out specific drugs or dosages or durations of treatment that are considered to be ototoxic. And there is also no nationally recognized and established document that does so. Therefore, we rely on each hospital to determine their own protocol for ototoxic medication administration and to follow that protocol. This section of the regs also indicates that physicians and audiologists are responsible for reporting any risks that are not known at birth. So if they're subsequent to the birth admission is a incidence of head trauma or a diagnosis of meningitis, it's the physician and audiologist's responsibility for reporting those. This slide shows you the risk indicators that are listed in the 2007 JCIH position statement. And that statement says that children who pass hearing screening but have one of these risk factors should have pediatric audiologic evaluation by 24 to 30 months of age, or sooner if appropriate. It's important to note that for some of these conditions it may be appropriate to have more frequent and earlier audiologic follow-up, and that should be determined by the physician and the audiologist. So this list represents a minimum standard. Hospitals may always choose to recommend follow-up at more frequent intervals or for additional conditions that aren't listed here. But these are the minimum standard, and so these are the risk indicators for which you must ensure the parents are aware of the need for additional follow-up. Also, the way our rules are written, if and when the Joint Committee on Infant Hearing updates their position statement, it was last updated in 2007. If they make a change in the near future and they change this list of risk indicators, whatever list they adopt will automatically be what's referenced in our rules, since we don't spell out these conditions by name in our rules and rather just make reference to the JCIH position statement. The next item, the next section, 1.9, indicates some things that should happen based on the screening results that you get. When a screening is done, regardless of the results, the birthing facility shall provide written notification of the results to the responsible physician and notify the parents of the results both face-to-face and in writing. So this is true, should notify the parents not just of a refer or a non-passing result, but also notify them that their baby passed, if that's the case. The requirement that parents be given results both face-to-face and in writing was added several years ago based on feedback and experiences to date from other hospitals. Notifying parents face-to-face, so verbally or with a sign language interpreter or another qualified interpreter present when appropriate, allows the parents to ask questions and allows the staff member to ensure that the parent understands the results and the next steps for follow-up when necessary. Providing the results in writing is also important since we know that new parents may be sleep-deprived, exhausted, medicated, and when we give them the results verbally, they're barraged with information and follow-up steps from other procedures and other things going on in the hospital to remember. So ensuring that they have the written documentation to back up what they were told will also help to ensure that needed follow-up occurs. I'd like to share a couple of stories with you about some experiences of parents. And because of these stories and other experiences and things that we've heard from parents, we strongly encourage the use of scripts, a specific written guideline of what screening staff should tell the parent. I'm going to show you a couple scripts that are developed by the National Centers for Hearing Assessment and Management. We have those available for you. You can write your own. So a couple of stories I have come from an event that the EHDI program co-sponsors every couple of years with some other programs, and is designed for parents and families of children with hearing loss as well as those children. And so these next couple stories are from parents that I met during one of those events. One parent had a child who did pass her newborn hearing screening. Turns out she had a condition that does frequently cause a late onset hearing loss that wasn't known at the time of birth. And the mother did know that her baby had passed. And because of that, she didn't initially suspect a hearing loss right away when her daughter's behavior changed. So it's important even when a baby passes their hearing screening that the parent be given information about what to look for. The flip of that is another parent I spoke to who told me how his daughter did refer on her inpatient hearing screening. But the screener also told this parent that most of the children that had been screened that day had referred, and there was probably something wrong with the equipment. And as a result, this parent didn't feel all that concerned and all that compelled, or that it was all that important to worry about getting a follow-up appointment. And so the family did delay for a considerable amount of time before getting follow-up, and it turned out as his daughter did have a hearing loss. So it's very, very important what staff communicate to new parents and how that communication is done so that we encourage the appropriate follow-up behaviors in those parents. So these are the NCHEM scripts. The first one is actually just informing the parents of the screen. It is a good idea to let families know that screening is being done. And the next thing on the screen is results or a script for when baby passes. So it's important to emphasize that they should continue to monitor speech and hearing. The Can Your Baby Hear brochure, which I mentioned in the last presentation and is available from our department, includes on the back cover a speech and language milestones checklist that parents can monitor. So if the baby passes hearing screening, the parent should be alerted to be aware of these speech and language development milestones, and if the baby's not meeting these milestones, to let their healthcare provider know. So it's a good thing to do when communicating the results of a pass. Communicating the results when the baby does not pass can be trickier and require some careful wording. Some parents may get overly upset or concerned when they think that there might be something wrong with their precious, wonderful, beautiful new baby. So there's sometimes a natural reaction of screeners to want to play down the results and calm the parents' fears. Like the experience with the dad I mentioned earlier. Oh, don't worry about it. You know, something must be wrong with the machine. So we need to be very, very careful. It is true that many children who do not pass their inpatient hearing screening will ultimately be found to have normal hearing. So certainly we don't want to convey the message that if the baby doesn't pass a screen that there's definitely a hearing loss. However, too much emphasis on playing down the result may create a situation where the parent isn't sufficiently motivated to seek follow-up care. It's a very careful line to walk here. We suggest that you stick with the facts as is scripted here. That you say that not passing the hearing screening doesn't necessarily mean that the baby has a hearing loss, but additional testing is needed to be sure. You may be able to draw parallels to other screening experiences a family has had. If the mother had a high glucose screening during her pregnancy and was required to do a 3-hour glucose test as a more definitive test, that might be an analogy. If a mother's ever had a abnormal pap smear and had to come back and have a repeat pap smear. There are many screening tests that people are exposed to. So most people are comfortable with the idea that sometimes the test result isn't definitive and additional testing might be needed. These NTEP scripts are also available translated into Spanish, and again, we can make those available to us if you contact our program. I'm going to show you a little pie chart now that tells you about the outpatient outcomes. This is for babies that were born in 2011 and had a non-pass or a refer result on their inpatient screening. So you can see that this big chunk, 2/3 of babies that did not pass their hearing screening, had an outpatient repeat screening test done, and they passed that outpatient rescreening. Another group, just under 10%, had outpatient diagnostic testing done, and they were found during that diagnostic testing to have normal hearing. This next wedge, 3.8% of babies that were diagnosed with hearing loss as their follow-up result to their newborn hearing screening. So this group is really the whole point of newborn hearing screening. And this slide shows you that about 3 to 4 of every 100 babies that do not pass their screening will be diagnosed with hearing loss. And it's at least 3 to 4. And I say at least because we do have some babies that we don't know their final hearing status, and I'll talk about that in a minute. And some of those babies who we don't know results for may have a permanent hearing loss. So the true number of children with a non-passing result that do have a hearing loss has to be at least this number and maybe higher. So this next group, about 4.5% of babies, are an interesting group. They did have some outpatient follow-up, but we at the Department of Health never received a final status of their hearing. Some of these babies had an outpatient rescreening and referred again on that second screening, and then were recommended to go for diagnostic audiologic follow-up, but never showed up for that follow-up. You see at the top of this chart, I've said this is data that was reported to the Department of Health EHDI program as of the end of July of 2013. So some of these babies may have come back in August or September, or they may come back in 2015 and show up. They may eventually be diagnosed with hearing loss. They may eventually be diagnosed with normal hearing. But at the time that we looked at the data and tried to find the follow-up status of these babies, it was still incomplete. Some of these babies may have had a diagnostic exam, but had an ear infection at that time, so that final results could not be determined. The EHDI program does outreach to contact the physicians, the audiologists, the families of these babies to try and ensure that they return for additional testing and that we get a final documentation of hearing status. But we can't always make that connection happen, and we have seen babies that have referred an outpatient rescreening, not shown up for diagnostic testing, and then eventually showed up at 4 or 5 years of age and been diagnosed with a hearing loss. So again, we're trying to work on this little wedge here and get it down. We also, unfortunately, have a pretty big chunk of pie here for whom we have no follow-up information reported. And this is why most of this presentation is talking about follow-up, what the hospital's obligations are for follow-up, and what hospitals can do to decrease the percent of babies that are lost to follow-up. Over the last several years, we have managed to decrease every year the rate, percent of lost to follow-up and the size of this piece of pie, but we've begun to plateau, and we really need the hospital's help in trying to reduce the rate of loss to follow-up. It may be that these families didn't take their babies for follow-up because they didn't know it was needed, or they didn't think it was that important. It could be that the family had financial or transportation barriers to follow-up. It could be they had follow-up, but the provider doing that outpatient testing was not aware of the requirement to report the results to us. We do conduct regular outreach in our EHDI program to audiologists, pediatricians, other healthcare providers to try and ensure that any outpatient testing that is done does get reported to us and documented, but we're continually trying to work on that. But we really rely on your help at the hospital to ensure that parents leave the hospital understanding that their child needs follow-up and how to go about scheduling that additional testing. This last tiny piece of pie is babies that we cannot document their hearing status, either because they died after discharge, they moved out of state, or that their parents refused additional follow-up testing. So back to the regs, that's sort of how we're doing, and back to the regs is how we're requiring hospitals to help us with that follow-up and helping that follow-up be as effective as possible. So our regs say that if hearing screening is missed, didn't get a chance to do the test in the hospital, or if the screening inpatient was not passed, you had a refer result, you're required to do a couple things. Again, providing written notification of the results to the responsible physician and notifying parents both face-to-face and in writing of the need for follow-up testing. We have a brochure that I mentioned during the last presentation called Your Baby Needs Another Test, and it should be given to all parents of babies with a refer result, and describes why they need another test and why it's important to have another test. One strategy recommended by some national groups that have done quality improvement initiatives that may assist the family in scheduling and getting an outpatient follow-up appointment is to actually encourage them to make an appointment even before they've been discharged from the hospital. So this brochure does have a place where you can jot down that information. We do know from talking to our hospital contacts that this strategy of making the follow-up appointment doesn't work well in all situations. Some hospitals have had great success with it. Others have found that the parents are too sort of discombobulated to know what their schedule is going to be and are more likely to be no-shows. But if you haven't tried it, it's a strategy we certainly recommend that you consider trying and give it a try just to see if it improves your follow-up rates. As was evident in the last slide, or really the one that showed you the pie chart, the usual practice for most New Jersey babies is that a refer on an inpatient screening is usually followed by an outpatient repeat screening exam. We do have a couple hospitals that always schedule babies for a full diagnostic evaluation as their first outpatient testing. And we actually don't have in our regs or have in our recommendations or even our suggestions a preference of one strategy over the other. But we do say that if your baby born in your hospital is going to be sent for outpatient rescreening or initial screening because they were missed in the hospital, you need to advise the parent that that should be done by 28 days of age. And if they're going to be referred for diagnostic testing, any diagnostic testing should be completed by 90 days of age. And you need to advise the parents of that. So you should be familiar with your hospital, either your hospital's audiology department, or if you don't have an audiology department, wherever your patients most likely follow up, what their routine is with respect to rescreening or diagnostic exam, and make recommendations accordingly. Okay, now if you've been falling asleep or doing some other work, I want you to pay attention and listen carefully, because what I'm going to say, again, is a recommendation. So it's not one of our bullets and it's not one of our requirements, but it's very important. And we do encourage you to suggest that parents schedule the follow-up as soon as possible after discharge, that they not necessarily wait until the 27th day for a rescreening, or they wait until the baby's 2.5 months old before scheduling a diagnostic appointment. There's a couple reasons for this. One, if they don't pass that screening and they need to go on for additional screening in order to meet our goal of having a complete diagnosis done by 3 months of age, we start to run out of time. But probably more importantly is, as you know this, you are very well aware that younger babies sleep more often and more readily than older babies. And screening and diagnostic exams are both done easiest when a baby is asleep and quiet. So if those outpatient follow-up appointments can happen when the baby is younger, it's much more likely that follow-up appointment will get a conclusive test result, instead of having the baby wake up and cry and have to come back for another visit and another visit. So the sooner they can get that follow-up done, the better, and that's a good message to routinely communicate to your families. Only about, just want to mention first, if there are risk indicators for late onset hearing loss, the hospital is required to notify the responsible physician in writing of those risks, and also to notify the parents, like with the results, both face-to-face and in writing, and notify the parents of the JCIH recommendation regarding additional follow-up and what those intervals are. Okay, so next, hospitals are also required to provide parents with information on where they can go for follow-up testing, because only about half of the hospitals in New Jersey with maternity services also have audiology departments. So knowing where follow-up can take place can be a challenge. We do have New Jersey hospitals that have the staff, the same staff that does the inpatient hearing screening, also conduct one outpatient rescreening exam. That's a strategy that we found to be very successful, where hospitals are attempting that, because the families are familiar with the location of the hospital and they're familiar with the nursery staff. It's important, though, that if they don't pass that first outpatient rescreening exam done by the nursery staff, then the hospital should be providing documentation of the repeat refer to the Department of Health, to the physician, to the parent, and also making sure at the time of the repeat refer that they receive information on where they can go for a full diagnostic audiologic evaluation. Now, if you don't know where to send the family for a rescreening or for a full diagnostic audiologic evaluation, we do have a directory available to help you. Maybe even you have your own audiology department, but you have a family that chose to travel some distance to give birth at your hospital and they want to have their follow-up closer to home. So you'll find our online directory useful in helping to locate a facility for additional testing. So you can find our directory on the EHDI website. Website is found on the back of our brochures. The QR code can be scanned and bring you there. You can search for facilities by a county or by a city or even just by the name of a facility to get more information about them. If you click on county type, I'll show you what happens. If I click on county type, and the screenshot is what you would find if you searched on Morris County. And you can see it lists the facilities. These are all audiologists and also some ENTs and hearing aid dispensers that responded to our request to ask if they wanted to be included in the directory. So again, it includes hospital-based audiology departments. It includes audiologists in private practice. It includes some ENT offices. And by starting off by searching for the county, it'll give you the name, the address, and the contact information. Notice that the directory also has the ability to map those locations and to be able to use that map to then get driving directions to those specific locations. And also, if you click on the name of the individual facility, you'll get more detail on the types of services that are offered at that facility. So as I noted earlier, I'm going to now provide some suggestions about follow-up and getting off of what's regulatorily required. So all of the items on this slide are not required by our administrative rules, but our EHDI program believes they can be very helpful in improving follow-up. So we encourage you to consider trying these strategies. So we like the use of a next steps document, and on the next slide I'm going to show you what one of those looks like. The goal of a next steps document is that just telling the parent, oh, you need to go get additional follow-up, is probably not sufficient enough in some instances to actually get them connected to that follow-up, and we need to be a little more specific and spell out those steps a little bit better. Another really good strategy is to have the family restate the next steps to ensure that they understood what it was they're supposed to do next. Also consider whether you're practicing cultural competence in your newborn hearing screening program in delivering the follow-up information to parents, and not just providing translation services, but being respectful of any family-specific needs. And I'm sure all New Jersey hospitals have efforts in place and in services and discussions on providing culturally and linguistically competent health care. Obviously, if a parent's primary language is not English, you should be securing qualified interpretation services when you let the family know the screening results. But you also should be sure to consider other aspects of culture. Is this a family that during the hospital stay has demonstrated that the father of the baby is the key decision maker in the family? Well, if that's the case, then you need to be sure when you're communicating the screening results and the need for follow-up that you're including the father in that conversation and not just the mother. Or maybe it's a family that has indicated that they rely on public transportation. Well, if you suggest an audiology facility for follow-up that's not close to a bus or a train route, then you really shouldn't be surprised if that family doesn't seek additional follow-up services. I think a really good way to be sure that you've both explained next steps, the families have understood the next steps, and the family's individual needs have been considered is after telling the family that they need additional follow-up and walking through the next steps, you end with, to make sure I was clear, can you tell me what it is you think you need to do next, and if you expect any problems with completing those steps? And that gives you the chance to assess if the family heard you, understood you, and gives them a chance to say, well, gee, I don't think I can get to that audiology facility because it's not on the bus route, or any other problem that they foresee. Oh, I've got 6 other kids that I'm going to have to arrange for child care for. I'm not sure if I'm going to be able to get out of the house to get my child in for follow-up care. So you can help families work through those sorts of issues only if you've given them the chance to voice them. I mentioned I would show you a sample next steps document, and here's the sample that I mentioned. One of the barriers to follow-up is that it's really just not as simple as just show up at XYZ audiology department. Audiology facilities typically require a prescription from the primary care provider in order to complete the testing. And also their insurance plan may require a referral from the primary care provider. An audiology facility typically wants to verify that the insurance coverage is in place. And before the insurance is even activated, parents usually need to notify the insurance company and may need to wait for an insurance card to arrive before completing the next steps for outpatient follow-up. So this next steps list includes the many things that may be necessary for follow-up. So it starts with contacting the pediatrician's office, calling the insurance company, and calling the audiology office. Now note that this is one hospital's example, and you may need to customize it for your facility. You can see I circled here that this hospital wrote for ABR rescreen because they're doing an inpatient ABR screening. They want to always ensure that their babies receive an ABR testing outpatient. So if you were doing OAE screening, copying this next step document verbatim would not be appropriate. Again, this hospital also, where they refer families to for outpatient audiology services, that location typically wants the families to have a photo ID in addition to the referral, the insurance card, and the prescription. So that was included on this document in mentioning those things. So you can see, again, there's a lot of steps, there's a lot of pieces to be involved, and so the more explicit you can make it for families and the more you can help walk them through those next steps, the more likely they are to actually complete that follow-up. Another requirement in our rules is that for babies that missed screening inpatient and for babies that referred on their inpatient screening, hospitals are required to make at least one reminder contact to the parent by mail, phone, fax, email, or text message. Again, we make this a minimum standard. You are always willing to exceed this. You're always able, if you're willing, to exceed the standard set by the rules. So if you want to do 2 or even 5 reminder contacts to a parent, you're welcome to do so. In our last rule change, we added the email or text message phrase to this requirement. If you have a parent that's more likely to use email or a cell phone and use those, and they're willing to provide you with their email or cell phone number when you say that you want to contact them, then you're welcome to do so, and that may be more effective. You also want to consider, and again, this is a suggestion or a recommendation, asking the parent, what is the best way we can reach you in a week or 2 to remind you about scheduling the hearing follow-up, and use that method. If they say by phone, ask which is the best phone number. So don't assume it's the home number that they listed on their registration form. It may be a cell phone number that's better. Also consider asking for a second point of contact. Say, hey, if I'm not able to reach you at this phone number that you just gave me, is there somebody else I can call? A relative, a work number instead of a cell number, the father of the baby's cell phone number in addition to the mother's cell phone number. Because we know that sometimes cell plans get exceeded, phones get turned off, people move, and we'd like to have a second way to contact that family if possible. The requirements in Section 1.10 we talked about in Part 1 as well because they apply to inpatient rescreening. So here they're referencing outpatient follow-up. Again, this is talking about outpatient follow-up, so in many cases it's applying to the audiology services, which is not necessarily an obligation or a responsibility of the hospital contact. But if your nursery screening staff is doing outpatient rescreenings, then this does apply to that follow-up testing. If you're always referring babies to an external audiology department outside your hospital, it applies to the person doing that exam. However, it's still important for you to be aware of this requirement when you do patient education. As I mentioned in reviewing the next step slide, if you're using ABR screening on all your babies, in the documentation you provide to parents about getting follow-up, you should also mention that when they call for an appointment, they need to stipulate that they need ABR rescreening. Audiology facilities that see primarily older patients frequently do not own ABR screening equipment, so you should not assume that any audiology facility in your area can meet this requirement. Our pediatric hearing healthcare directory that I referenced in the earlier slide does indicate facilities that are able to do ABR rescreening. This section of the rules, 1.10c, indicates that providers need to file our SCH3, Special Child Health Services 3 form, which is also known as the Loss to Follow-Up form, if reminder contacts are unsuccessful in the baby receiving follow-up. So this form, the purpose of this form is really to document that the hospital did in fact make that required follow-up that was required in Section 1.9 in cases where no follow-up ever eventually happened. The Loss to Follow-Up form looks like this. This is the paper version of the form. It is available for download as a PDF or Word document file on our website. We also have the quadruplicate copies, so you can send copies to the physician as well and keep one and send one to us if you ask our program for them. In addition, the other way you can file the Loss to Follow-Up form is electronically. The EHDI program has an interface built into the New Jersey Immunization Information System, New Jersey's Immunization Registry. An advantage of using the NJIIS system is that it also allows you to see any outpatient follow-up that has occurred. It's our mechanism that we use for reporting the outpatient follow-up, as well as reporting loss to follow-up. This is a screenshot from the training version of the database. So this is fake baby and fake audiology facility information here. And if you're logged into the system, again, it does let you see the inpatient screening results for a baby, any outpatient screening or diagnostic results that have been submitted, and it allows you as well as audiology facilities to document a loss to follow-up form for a child. If you have staff that you would like to have be able to access the EHDI module in the NJII system, please just contact our program so that you can complete the necessary enrollment documentation and receive training. The other advantage of using the NJIIS system over the paper version of the form is that when you go into the system and you click on the form, this demographic section fills in for you automatically. If you're filling out the paper version of the form, you have to handwrite all that information in all those fields. And then after that fills in, you would just need to check the appropriate boxes and fill in the follow-up contacts that you have completed. Moving on, in our regs, at section 1.11, most of this applies to audiologists, since it's about the requirements for what has to happen when a hearing loss is diagnosed. So it mentions that audiologists or the diagnosing provider has to report the results both to the EHDI program as well as to the birth defects registry. So I'm going to skip over most of what's in this section of the regs. However, I am going to highlight 1.11, item A, item 2C, where we talk about ear canal atresia. And since ear canal atresia must be reported to the birth defects registry prior to discharge from the birthing facility, and that bone conduction ABR testing should be done for these children prior to 3 months of age. Ear canal atresia can take on many severities and degrees and forms. As you can see from the pictures here, we have the baby that has a normal and intact looking pinna but no opening to the ear canal. We can see a somewhat misshapen ear and a very misshapen ear and a no ear at all child. One of the things that we really want to reinforce, so again, wake up, stop checking your email, pay attention. For any ear anomaly, don't automatically do a hearing screening on that ear. If the ear looks abnormal, first have an audiologist or physician perform an otoscopic exam of the ear. If the canal is open, meaning that audiologist or physician is able to visualize the tympanic membrane, the eardrum, then it's okay to screen. But if the tympanic membrane cannot be visualized, do not screen. If you have any doubt about the patency of the ear canal, well, it looks like there's a canal, but I can't see if it goes all the way through or not. Again, do not screen and refer that child to an audiologist. Mention that these children need a bone conduction ABR testing. It doesn't mean if they don't have an ear that they're exempt from screening, because the status of the internal structure of that ear can be assessed through a bone conduction ABR test. Our Pediatric Hearing Healthcare Directory can help you find facilities in your area that are capable of doing a bone conduction ABR testing. And not until that testing is done do we consider that child to have completed screening. If you try and use your piece of hearing screening equipment, be a lot pretty hard when there's no ear. But if you see sort of a misshapen ear and you attempt to use your screening machine anyway, regardless of what result it gives you, you should know that it's not deemed reliable, that screening an abnormally shaped ear is considered off-label use of equipment, and the equipment manufacturer will not stand by any of the results. If the machine inappropriately generates a pass result, and we have seen cases where that has happened, where a misshapen ear was screened, the equipment said pass, but ultimately the child was diagnosed with a significant hearing loss, then the parent has gotten a false sense of assurance about their hearing status and may not show up as timely for outpatient testing. So again, if there's any doubt as to the patency of the ear canal, do not screen. Refer them to an audiologist. Again, we want that bone conduction ABR to be completed by 3 months of age, so find a bone conduction ABR facility and have them make the appointment before they're 3 months old. Another suggested referral for children with ear canal atresia is that New Jersey does have a group of regional cleft palate and craniofacial centers that have multidisciplinary teams that are focused on serving families of children with cleft palates and other craniofacial issues. And you can find the list of those centers on the Department of Health's website. All right, the next few items in our rules, and I'm almost done, so hang in there, don't really have a direct impact on hospitals and you as a hospital contact, but I went ahead and covered them on this last slide just to be comprehensive in this presentation. So item 1.12 mimics the language in our law that allows us to create a registry and basically gives us the authority to collect the hearing screening information from hospitals and to also collect follow-up information. Item 1.3 indicates that the data that we collect as part of this law and this administrative code is confidential and is not subject to OPRA. OPRA is the Open Public Records Act. It allows external agencies like the press to ask for state government information, and we're required to release information they ask for, except in certain circumstances, and this is one of them. And finally, item 1.14 says that individuals or organizations who are reporting information to the State Department of Health hearing screening program, so you reporting to information to us, you cannot be held liable for divulging confidential information because it's required by our law and our rules. Again, if you have any questions, please don't hesitate to contact our program. We have a program email address, which is eddy@doh.state.nj.us. The main phone number for our EHDI program is 609-292-5676. We at the State EHDI program are here to help and support the hospitals in implementing their programs and are happy to help you in any way that we can to help your programs be running smooth and hopefully to identify hearing loss early. So just like on these cute little babies with their hearing aids in, we can get early intervention and amplification services to children and help to maximize their speech and language development. I thank you for joining me for this presentation today. We do have one final part of our EHDI for Hospital Contacts series. Part 3 will focus on the quarterly reports that we send out to hospitals, what the data means, what it should look like, and what you should be doing when you receive those reports in the mail. So I hope you join me for that presentation as well, and I hope you have an excellent day. Thank you.